System failure, the silent alarms of kidney collapse. The human body is a fortress, but its most critical defense system operates in total silence. Your kidneys filter toxic chaos from your blood every second, yet when they begin to fail, they rarely scream, they whisper. Millions stand on the precipice of total renal shutdown, oblivious to the chemical storm brewing within. These aren't just symptoms, they are biological distress signals often dismissed until the damage is irreversible. To survive the silent killer, you must decode the body's cryptic language, starting with a disturbing shift in your daily routine.
Frequent urination changes, the catastrophic disruption, and the loss of concentration. To understand the catastrophic implications of altered urination patterns, one must first appreciate the architectural marvel that is the human kidney. It is not merely a passive filter, it is a dynamic, high-functioning chemical refinery that operates on a precise circadian rhythm, orchestrating the balance of fluids and electrolytes with a level of sophistication that eclipses modern dialysis machines. In a healthy individual, this system is a silent metronome. The kidneys filter approximately 150 quarts of blood daily to produce about 1 to 2 quarts of urine. This output is strictly regulated by a complex interplay of hormones, blood pressure, and neural signals. However, when the renal infrastructure begins to crumble, the first casualty is often the organ's ability to concentrate urine, leading to the insidious and frequently overlooked symptom of changes in urination frequency. This is not simply a matter of visiting the restroom more often, it is a fundamental breakdown of the body's hydrological cycle. The most pervasive and early warning sign within this category is nocturia, the excessive need to urinate during the night. Historically and clinically, this is often the canary in the coal mine for chronic kidney disease, or CKD. To grasp why this happens, we must zoom in to the microscopic level of the nephron, specifically the renal tubules. In a functioning kidney, the tubules possess the critical ability to reabsorb water back into the bloodstream, concentrating the waste products into a smaller volume of urine. This process is heavily influenced by antidiuretic hormone, or ADH, which typically surges at night to suppress urine production, allowing for 6 to 8 hours of uninterrupted sleep. When the renal tissue sustains damage, whether from hypertension, diabetes, or glomerulonephritis, the tubules lose their sensitivity to ADH and their structural integrity. They become scarred and fibrotic, unable to effectively reabsorb water. Consequently, the kidney can no longer concentrate the urine. It defaults to producing a high volume of dilute urine, regardless of the time of day. This forces the patient to wake multiple times a night, shattering their sleep cycle and initiating a cascade of fatigue and physiological stress. The phenomenon of polyuria, excessive urination, represents the initial phase of this failure. Patients often report a sensation that fluids are passing through them straight away, regardless of their hydration status. This is the isosthenuria phase, where the specific gravity of the urine becomes fixed, mirroring that of the plasma. The kidney has lost its dynamic range. It can neither dilute nor concentrate. It is stuck in a fixed gear. This stage is particularly treacherous because it mimics other less severe conditions. A patient might dismiss the symptom as a natural consequence of aging, a side effect of caffeine consumption, or perhaps a minor prostate issue in men. However, chemically, this represents a massive failure of the countercurrent multiplication system within the loop of Henle, the U-shaped portion of the tubule responsible for creating the concentration gradient in the kidney's medulla. When this gradient collapses, water flows out of the body unchecked. Conversely, and often in later stages or acute scenarios, the pendulum swings violently to oliguria, decreased urine output, or anuria, total cessation. This is the terrifying inversion of polyuria. As the glomerular filtration rate, GFR, plummets below critical thresholds, the kidneys simply stop processing fluid altogether. The toxins and fluids that should be expelled are trapped within the vascular system and the tissues. This is not merely a mechanical blockage, but a cellular shutdown. The glomeruli, the tiny tufts of capillaries that act as the initial filter, sclerose and harden. The surface area available for filtration diminishes until it is negligible. The psychological impact of this transition is profound. Patients who spent months annoyed by frequent bathroom trips suddenly find themselves producing less than 500 milliliters of urine a day, despite consuming fluids. This silence from the bladder is deafening. It signals that the body is turning into a closed loop, recirculating its own waste. The historical context of urinalysis underscores the gravity of these changes. For millennia, physicians practiced uroscopy, the diagnostic inspection of urine. Ancient healers, lacking MRIs or blood tests, understood that the volume, color, and frequency of urination were the most direct windows into the body's internal state. In the Middle Ages, urine wheels were used to diagnose dropsy, edema, and kidney failure based on these very fluctuations. Today, while we have advanced diagnostics, The patient's self-reported history of urination changes remains the cornerstone of early detection. The tragedy lies in the modern tendency to normalize these symptoms. In a society fueled by high fluid intake trends and diuretics like coffee, the subtle increase in frequency is lost in the noise of daily life until the damage has progressed to stage 3 or 4 CKD. Furthermore, the urgency aspect cannot be ignored. The damage to the kidneys often creates a neurogenic disconnect. The accumulation of toxins can irritate the bladder lining and the nerves controlling the detrusor muscle, leading to sudden, uncontrollable urges to urinate. This adds a layer of social anxiety and lifestyle limitation that compounds the physical ailment. The patient becomes tethered to the location of the nearest restroom, altering their travel, work, and social interactions. This behavioral change is a direct downstream effect of the toxic environment brewing in the blood. The urea and creatinine that are not being effectively cleared act as irritants. Thus, the change in urination is not just about volume. It is about the loss of control, the loss of sleep, and the loss of the body's ability to self-regulate its most basic housekeeping function. The investigation into urination changes also requires a look at the quality of the stream and the sensation. While often associated with prostate issues in men, a weak stream or a feeling of incomplete emptying can also signal renal distress when coupled with the systemic toxicity of kidney failure. The body, in its attempt to manage fluid overload, may create a paradoxical retention scenario. The intricate feedback loops involving the renin-angiotensin-aldosterone system, or RAS, which regulates blood pressure and fluid balance, go haywire. The kidneys, thinking the body is dehydrated due to poor blood flow, a common issue in heart failure linked to kidney disease, may aggressively hold on to sodium, altering the osmotic balance and changing the urination pattern further. This creates a confusing clinical picture where the patient is fluid overloaded yet urinating frequently in small amounts, or conversely, dehydrated yet unable to concentrate urine. Ultimately, identifying this sign requires a high degree of body awareness. It necessitates tracking the ins and outs, a practice standard in intensive care units but foreign to daily life. A sudden shift where one goes from sleeping through the night to waking up twice.
The 3 times is a biological siren. It indicates that the tubulo-interstitial compartment of the kidney, the machinery responsible for the fine-tuning of our internal ocean, is under siege. Ignoring this sign allows the fibrosis to spread, turning the pliable, functioning kidney tissue into useless scar tissue. By the time the frequency decreases into oliguria, the window for preventative intervention has often closed, leaving dialysis or transplantation as the only remaining paths.
2. Persistent fatigue, the suffocation of the cells and the uremic fog. If frequent urination is the mechanical failure of the plumbing, persistent fatigue is the systemic failure of the power grid. This is not the tiredness one feels after a long day of work, nor is it the exhaustion that follows a poor night's sleep. The fatigue associated with kidney failure is a profound, marrow-deep lethargy that rest cannot cure. It is a biological state of depletion that permeates every cell in the human body. To understand this symptom, we must dismantle the misconception that the kidneys are merely waste disposal units. In reality, they are also endocrine organs, vital producers of hormones that dictate oxygen delivery and metabolic energy. When the kidneys fail, they initiate a dual assault on the body's energy systems, the cessation of red blood cell production and the accumulation of metabolic poisons. The primary driver of this crushing fatigue is renal anemia, a condition inextricably linked to the hormone erythropoietin, EPO. In a healthy body, specialized cells in the kidney's cortex act as oxygenexers. When they detect low oxygen levels in the blood, they release EPO, which travels to the bone marrow and stimulates the production of red blood cells, erythrocytes. These cells are the cargo ships of the circulatory system, carrying hemoglobin, which binds to oxygen and delivers it to tissues, muscles, and the brain. As kidney function declines, these EPO-producing cells are damaged or destroyed. The signal to the bone marrow fades and eventually silences. The bone marrow, awaiting instructions that never arrive, slows its production of red blood cells. The result is a precipitous drop in hemoglobin. Without sufficient red blood cells, the body is essentially suffocating on a cellular level. Muscles are deprived of the oxygen required to generate ATP, the energy currency of life. Even minor exertion, climbing a flight of stairs, carrying groceries, simply walking to the mailbox, becomes a Herculean task requiring recovery time. The heart, attempting to compensate for the thin, oxygen-poor blood, beats faster and harder, leading to left ventricular hypertrophy and further exhausting the patient. This is a physiological starvation of oxygen that no amount of sleep can rectify because the deficit is in the transport mechanism itself. However, anemia is only half of the equation. The second,
Equally devastating component is uremia, literally urine in the blood. As the kidneys lose their filtration capacity, measured by the glomerular filtration rate, or GFR, nitrogenous waste products like urea, creatinine, and guanidino compounds accumulate in the bloodstream.
These toxins are metabolic depressants. They cross the blood-brain barrier and interfere with neurotransmitter function, leading to what is clinically described as uremic encephalopathy in its severe stages, but manifests early on as a thick, impenetrable mental fog. Patients describe the sensation as moving through molasses or living in a dream state where cognitive processing speed is significantly slowed. This chemical toxicity affects the mitochondria, the power plants of the cells. Research has shown that uremic toxins can inhibit mitochondrial respiration, effectively dimming the lights in every room of the body's house. The fatigue is therefore both central, brain-based, and peripheral, muscle-based. The accumulation of acidic waste products leads to metabolic acidosis, a condition where the body's pH drops below the optimal 7.35 to 7.45 range. In an acidic environment, enzymes function poorly and protein structures destabilize. The body must expend immense amounts of energy trying to buffer this acid, primarily by breaking down muscle protein, which leads to muscle wasting, sarcopenia, and further weakness. It is a vicious cycle of catabolism, where the body eats itself to survive the toxic environment, leaving the patient physically hollowed out. The historical perspective on this fatigue is sobering. Before the advent of synthetic EPO in the late 1980s, patients with end-stage renal disease, ESRD, were dependent on repeated blood transfusions to survive, living in a permanent state of severe exhaustion. The introduction of erythropoiesis-stimulating agents, ESAs, revolutionized nephrology, proving that the fatigue was not merely a side effect of being sick, but a specific hormonal deficiency. Yet, even with modern treatments, the fatigue often persists because the uremic toxins remain until dialysis or transplantation clears them. This residual fatigue is one of the most reported and debilitating complaints of kidney patients, often leading to misdiagnoses of depression or chronic fatigue syndrome before the renal origin is discovered. The impact of this fatigue extends into the psychosocial realm, often destroying the patient's livelihood and relationships.
Because the patient may not look acutely ill in the early stages, perhaps just slightly pale, their exhaustion is often interpreted by employers and family members as laziness or disinterest. The invisible nature of renal fatigue creates a barrier of isolation. The patient loses the volition to socialize, to pursue hobbies, or to engage in intimacy. Libido crashes due to both the physical lack of energy and the hormonal imbalances, such as reduced testosterone, that accompany kidney failure. The world shrinks to the size of their bedroom. Furthermore, the fatigue acts as a mask for other symptoms. When a patient is too tired to move, they may not notice the shortness of breath on exertion, entry number 9, or the muscle weakness, entry number 7, because they have subconsciously limited their activity to avoid these sensations. It becomes the dominant symptom that swallows all others. In clinical interviews, patients often retrospectively realize that their fatigue began years before their diagnosis. They adapted by drinking more caffeine, sleeping earlier, and cutting back on gym time, rationalizing the decline as getting older or stress. This normalization is dangerous because the underlying cause, the progressive scarring of the renal tissue, continues unabated. It is also critical to analyze the sleep disruptions that compound this fatigue, as mentioned in entry number 1, nocturia fragment sleep. But beyond that, kidney failure is strongly linked to sleep apnea and restless leg syndrome, RLS. The buildup of toxins affects the nervous system, causing twitching and discomfort in the limbs that make deep restorative sleep impossible. Thus, the patient is hit on all fronts. They are anemic, low oxygen, uremic, toxic blood, acidotic, chemical imbalance, and sleep deprived. This quadruple threat creates a level of exhaustion that is incompatible with a normal quality of life. Scientific inquiry into the uremic milieu continues to uncover new toxins that contribute to fatigue. Indoxyl sulfate and P-cresyl sulfate, the protein-bound toxins that are difficult to remove even with standard dialysis, are now understood to induce oxidative stress and inflammation. This systemic inflammation, often indicated by high C-reactive protein levels, keeps the body in a constant state of fighting, burning energy reserves to combat a phantom infection that is actually the body's own waste. The immune system is chronically activated but ineffective,
draining resources that should be used for daily living. In conclusion, the fatigue of kidney failure is a total system collapse. It is the result of the body losing its oxygen delivery system, its waste removal system, and its chemical balance simultaneously. It is a heaviness that weighs down the soul as much as the limbs. Recognizing this fatigue, distinguishing it from the tired but wired feeling of stress or the sleepy lethargy of depression is vital. It requires a blood test to reveal the silent story, a rising creatinine, a falling hemoglobin, and a pH drifting toward acidity. When the body runs out of fuel and fills with exhaust fumes, it is not just asking for rest, it is signaling that its filtration engines are failing.
3. Swelling, edema, the hydraulic collapse, and the drowning of the self. To witness the onset of renal edema is to watch the human body slowly succumb to the physics of its own environment. It is a transformation that is at once grotesque and fascinating, a biological rebellion where the internal ocean that sustains life breaks its banks and floods the habitable zones of the tissues. In the lexicon of nephrology, this is not merely swelling, it is the catastrophic failure of fluid dynamics, a breakdown of the delicate equilibrium described by Starling's law, which governs the movement of fluid between the capillaries and the interstitial spaces. When the kidneys fail, they cease to be the master regulators of volume. They become dams that have burst, not outwardly, but inwardly, trapping the patient in a rising tide of their own saline. The mechanism behind this swelling is a complex interplay of pressure and chemistry, centered primarily on the molecule albumin and the element sodium. Albumin is the most abundant protein in human blood plasma, produced by the liver but preserved by the kidneys. Its primary function in this context is to maintain oncotic pressure, essentially the magnetic force that holds water inside the blood vessels. In a healthy system, the kidneys act as vigilant gatekeepers, ensuring that while toxins are expelled, albumin is retained. However, in the throes of kidney failure, specifically in conditions like nephrotic syndrome, the glomerular filtration barrier becomes permeable to proteins. Albumin leaks out of the blood and into the urine, a phenomenon inextricably linked to the next entry. As blood albumin levels plummet, the oncotic pressure collapses. The blood vessels lose their ability to hold water. Consequently, fluid leaks out of the circulatory system and pools in the surrounding tissues. The body is effectively dehydrating its veins while drowning its skin. Simultaneously, the failing kidneys lose their ability to excrete sodium. Sodium is the Pied Piper of water. Where it goes, fluid follows. In a healthy individual, the kidneys filter excess dietary salt and excrete it. In renal failure, this mechanism jams. Sodium accumulates in the body, triggering an intense thirst response and forcing the body to retain water to dilute the salt concentration. This creates a hypervolemic state, an overload of volume. The heart, already strained, pumps against this excess fluid,
pushing it out into the extremities where gravity takes over. This is why the swelling often manifests first in the ankles and feet, pedal edema. It is a gravitational accumulation of failure. By the end of the day, a patient's legs may resemble tree trunks, the skin stretched taut and shiny, stripping away the anatomical definition of the ankle bone. The clinical hallmark of this type of swelling is pitting edema. It serves as a visceral diagnostic test that dates back centuries. If one presses a thumb firmly into the swollen flesh of a kidney patient and holds it for 5 seconds, the indentation remains long after the digit is removed, like a footprint in wet sand. This pit is physical proof that the fluid is not within the cells, but third spacing, trapped in the interstitial wasteland between them. It is a haunting sensation for the patient, a tactile reminder that their flesh has lost its elasticity and resilience. The severity is often graded on a scale from 1+ to 4+, with 4+ representing a pit that is nearly an inch deep and takes minutes to rebound. This is not just cosmetic, it is painful. The skin stretches to its breaking point, causing microtears and increasing the risk of cellulitis and ulcers. The weeping of edema, where clear fluid literally seeps through the pores of the skin, is the terminal stage of this regention, a sign that the tissue can hold no more. However, renal edema is not confined to the legs, it respects no boundaries. One of the most specific early signs of kidney issues, distinguishing it from heart failure, is periorbital edema, swelling around the eyes. Because the tissues of the eyelids are loose and have low turgor pressure, fluid accumulates there easily, especially during sleep when the patient is horizontal and gravity redistributes the edema from the legs to the face. Patients wake up with puffy eyes, often dismissing it as allergies or a bad night's sleep. But this puffiness is the face of albumin loss. It is the visual signature of the kidney's inability to keep protein in the blood. As the day progresses and the patient stands up, gravity pulls the fluid back down to the legs, creating a diurnal cycle of swelling that moves through the body like a tide. The historical context of edema, historically termed dropsy, paints a grim picture of humanity's long struggle with this symptom. For millennia, dropsy was viewed not as a symptom but as a disease in itself. Ancient Greek and Roman physicians,
lacking the understanding of renal physiology, believed the flesh was literally melting into water. Treatments were barbaric, involving bloodletting to reduce the volume or the use of toxic diuretics like mercury, which often poisoned the kidneys further. It wasn't until the work of Richard Bright in the 19th century, who famously correlated dropsy, albumin in the urine, and hardened kidneys during autopsies, that the medical community understood swelling was merely the external flag of an internal renal collapse. Bright's disease, as it was known, cemented the link between the swollen limb and the dying kidney. The psychological impact of this transformation is profound and often under-discussed in clinical literature. The patient watches their body morph into an unrecognizable shape. Shoes cease to fit. Wedding rings must be cut off to prevent gangrene as fingers swell to the size of sausages. The face in the mirror becomes a stranger's, bloated, waxy, and distorted. This moon face, often exacerbated by steroid treatments for kidney disease, strips the patient of their identity. There is a heaviness to the existence of the edematous patient. The extra fluid can weigh 10, 20, or even 40 pounds. Every step requires lifting this parasitic weight. The simple act of walking becomes a resistance exercise. The lungs, too, fall victim to this flood. Pulmonary edema, fluid in the air sacs, is the lethal culmination of this process, where the patient effectively drowns in their own plasma, gasping for air that cannot penetrate the fluid barrier, a precursor to the shortness of breath detailed in later entries. Furthermore, the management of this swelling is a precarious tightrope walk. Diuretics or water pills are the standard weapon, forcing the kidneys to dump sodium and water.
But in a failing kidney, the response to diuretics diminishes, the nephrons become resistant. Higher and higher doses are required, which can lead to electrolyte imbalances, hearing loss, ototoxicity, and further kidney damage. It is a war of attrition. The patient is often placed on strict fluid restrictions, sometimes limited to less than 1 liter of liquid per day. Imagine the torture of the thirst mechanism screaming for water due to high sodium levels, while the patient is forbidden from drinking because their body cannot excrete it. They are thirsty in a body that is drowning. Culturally, the swollen body has often been misinterpreted as gluttony or obesity,
leading to social stigma. The distinctions between adipose tissue, fat, and edema fluid are lost on the casual observer. A patient in end-stage renal failure may look large, but is actually suffering from severe muscle wasting, cachexia, masked by liters of water. This sarcopenic obesity is a metabolic disaster zone. The fluid acts as a barrier to nutrition and healing. It compresses capillaries, reducing blood flow to the skin and making wounds impossible to heal. A simple scratch on an edematous leg can turn into a non-healing ulcer that leads to amputation. In the future of nephrology, the management of edema is moving towards bioimpedance spectroscopy, technology that passes a small electrical current through the body to measure the exact volume of fluid versus lean tissue. This allows for precise dry weight estimation, guiding dialysis and medication. But until the kidneys are repaired or replaced, the swelling remains a constant looming threat. It is the physical manifestation of the kidney's silence. When the kidney stops speaking, the body starts swelling, filling the silence with fluid until the pressure becomes unbearable. It is a hydraulic crisis that signals the filtration plant has shut down and the floodgates are open.
Foamy or bloody urine, the barrier breach, and the visual alarm. If edema is the result of the crime, foamy and bloody urine are the smoking guns at the scene. In the investigation of kidney failure, the toilet bowl becomes the primary diagnostic instrument, a ceramic basin that captures the most direct evidence of organ distress. While frequent urination speaks to the volume and concentration mechanisms, the appearance of the urine, specifically its texture and color, speaks to the structural integrity of the kidney itself. We are dealing here with the microscopic violence of the glomerular barrier, a biological sieve so sophisticated that it can filter liters of blood while retaining molecules as small as albumin. When this barrier is breached, the result is a visual alarm that no patient should ignore: the presence of foam, protein, or blood, erythrocytes, in the urine. Let us first dissect the phenomenon of foamy urine. It is crucial to distinguish this from the transient bubbles caused by a rapid stream hitting the water, which dissipate quickly. Pathological foam is stable, it layers, it persists, and it resembles the head on a poured beer or beaten egg whites. This resemblance is not coincidental, it is chemical. The foam is caused by proteinuria, specifically albuminuria. Albumin is a protein with surfactant properties, similar to soap. Surfactants lower the surface tension of a liquid. When albumin escapes the blood and enters the urine, it changes the fluid dynamics of the stream. As air is introduced during urination, the albumin traps it, creating a stable foam that requires multiple flushes to clear. To understand the gravity of this foam, one must zoom into the glomerulus, the tiny ball of capillaries where filtration occurs. Wrapped around these capillaries are specialized cells called podocytes. These cells are the guardians of the kidney. They possess long finger-like projections, foot processes, that interlock to form filtration slits, bridged by a thin membrane called the slit diaphragm. This structure is the ultimate barrier. It allows water and small toxins to pass, but physically blocks large proteins like albumin. In diseases like diabetic nephropathy or focal segmental glomerulosclerosis, FGSS, these podocytes are injured. Their foot processes efface, flatten, and the cells detach and die. Podocytes, unlike many other cells, do not regenerate easily. Once they are lost, the barrier is compromised.
The sieve develops gaping holes. Protein pours through. This leakage is the biochemical equivalent of a hull breach on a submarine. Albumin is not just a waste product, it is a vital resource. It transports hormones, vitamins, and drugs throughout the body. Losing it in the urine is a massive metabolic expense. The liver tries to compensate by overproducing proteins, which inadvertently leads to the overproduction of cholesterol, linking kidney disease to heart disease. The foam in the toilet is the visual indicator of this metabolic chaos. Historically, physicians practiced uroscopy, shaking a vial of urine to see if foam appeared. Today, the dipstick test detects this protein instantly, but the patient sees it first. The foam is often the earliest sign of kidney damage, appearing long before the GFR drops or the creatinine rises. It is the harbinger of the silent scarring occurring in the nephrons. Moving from texture to color, we encounter the terrifying specter of hematuria, blood in the urine. This is the visual scream of the kidney. While blood in the urine can originate bladder, ureters, urethra, kidney origin hematuria has a specific sinister character. When blood leaks from the glomerulus, it must travel through the long, twisting tubules of the nephron. During this journey, the red blood cells are subjected to osmotic stress and pH changes. They are battered, deformed, and oxidized. By the time they reach the toilet, the blood often does not look like fresh, bright red blood. It looks like Coca-Cola, tea, or smoky soot. This dysmorphic hematuria is a hallmark of glomerulonephritis, inflammation of the kidney's filtering units. It indicates that the basement membrane of the capillaries has ruptured. The violence at the microscopic level is extreme. The immune system is often attacking the kidney tissue, as in lupus or IgA nephropathy, blasting holes in the vessel walls. The red blood cells are squeezed through these gaps, resulting in acanthocytes or Mickey Mouse-shaped cells when viewed under a microscope. The presence of these cells confirms that the bleeding is intrinsic to the kidney, not a result of a kidney stone or a bladder tumor. However, not all hematuria is visible to the naked eye. Microscopic hematuria is a silent, gross hematuria, visible. The psychological impact is immediate. It shatters the illusion of health.
To see one's waste turned into blood is a primal signal of mortality. It provokes immediate anxiety, driving patients to the emergency room. Yet, in the context of chronic kidney failure, this bleeding can be intermittent. A patient may pass tea-colored urine during a viral illness, a classic sign of IgA nephropathy, and then see it clear up, leading to a false sense of security. But the inflammation continues, the scarring sclerosis progresses, and the nephrons slowly die off. The combination of foam and blood, protein and erythrocytes creates a nephritic sediment, a toxic sludge that further damages the kidney tubules as it passes through. The iron released from the broken red blood cells is toxic to the tubular cells, causing oxidative stress and accelerating the failure. It is a self-perpetuating cycle of damage. The foam indicates the filter is too open. The blood indicates the filter is broken. Together, they paint a picture of an organ that is disintegrating structurally. Culturally and historically, the interpretation of urine color has been a central pillar of medicine. In medieval times, the piss prophets would hold urine flasks to the light, divining the balance of the four humors. Bloody urine was seen as a sign of heat or excess blood humor, treated with leeches. Foamy urine was often associated with wasting diseases. Today, we understand the molecular truth, but the diagnostic power remains unchanged. The toilet bowl is the first line of defense. In the modern era, the presence of these signs dictates the urgency of a biopsy. A kidney biopsy is the definitive step, where a needle is plunged into the organ to extract a core of tissue. This tissue reveals the timeline of the destruction, how many glomeruli are scarred, sclerosis, how many are inflamed, and how many are dead. But the biopsy is invasive. The foam and the blood are the non-invasive warnings that demand attention. Ignoring foamy urine because it flushes away is a critical error. It allows the proteinuria to continue unchecked. Proteinuria itself is toxic to the kidney. As proteins we absorb by the tubules, it triggers inflammation and fibrosis. The foam is not just a sign of damage, it is a driver of progression. We must also consider the casts that often accompany these signs. When protein and blood cells congeal in the tubules, they form cylindrical molds called casts. These are flushed out into the urine.
Red blood cell casts are pathognomonic for glomerulonephritis. They are literally the fossilized remains of the bleeding event within the kidney. Finding them under a microscope is the clincher for a diagnosis of kidney failure driven by inflammation. In conclusion, foamy and bloody urine represent the structural annihilation of the kidney's filtration barrier. They are the debris of a microscopic war. The foam tells us the shield is down. The blood tells us the walls are breached. In the narrative of kidney failure, this is the turning point where the damage moves from biochemical, invisible, to macroscopic, visible. It is the moment the body externalizes its internal decay, demanding that the observer look down and acknowledge the crisis. To flush without looking is to ignore the most vivid distress signal the human body can generate. The color and texture of our waste are the daily status reports of our survival, and when they turn to foam and blood, the system is in critical condition.
5. Difficulty concentrating, the uremic fog, and the erosion of the self. The disintegration of the human mind is perhaps the most terrifying aspect of physiological failure, yet in the context of kidney disease, it is often the most subtle and insidious early warning sign. When we speak of difficulty concentrating, we are not referring to the momentary distraction of a busy afternoon or the forgetfulness that accompanies aging. We are describing a systemic chemical assault on the neural architecture of the brain, a condition clinically known as uremic encephalopathy. To understand this phenomenon, one must recognize that the brain and the kidneys are inextricably linked through a complex hemodynamic and metabolic axis. The kidneys are the guardians of the blood's chemical purity. When they falter, the blood becomes a toxic sludge that bathes the delicate neurons of the cerebral cortex in a poisonous milieu, slowly suffocating the very seat of consciousness. The cognitive decline associated with early kidney failure is driven by the accumulation of neurotoxins that a healthy renal system would typically flush out. While urea and creatinine are the standard markers measured in blood tests, they are merely the canaries in the coal mine. The true culprits of cognitive dysfunction are a host of middle molecules and protein-bound uremic retention solutes, such as guanidino compounds, indoxyl sulfate, and p-crysyl sulfate. These compounds are metabolic waste products derived from dietary protein and gut bacteria. In a functioning body, they are swiftly excreted. In a failing body, they accumulate in the serum, eventually crossing the blood-brain barrier, the fortress wall meant to protect the brain from pathogens and toxins. Once inside the central nervous system, these toxins act as synaptic disruptors. They interfere with the transmission of neurotransmitters like GABA, gamma-aminobutyric acid, and dopamine, effectively jamming the signals between neurons. The subjective experience of this toxicity is often described by patients as a brain fog or a cotton wool mind. It begins innocuously. A patient might find themselves reading the same paragraph in a book 3 times without comprehending it. They might struggle to balance a checkbook, a task that was once second nature, or find themselves unable to follow the plot of a movie. This is the subclinical phase of encephalopathy. It is a slowing of processing speed, a latency in retrieving words,
and a fragmentation of working memory. The brain is literally wading through a chemical swamp. As the glomerular filtration rate, GFR, continues to decline, the fog thickens. The toxins begin to depress the central nervous system in a manner similar to alcohol or sedatives, but without the euphoria. The patient feels perpetually hungover, their mental acuity dulled by the circulating nitrogenous waste. We must also consider the role of vascular pathology in this cognitive decline. The kidneys and the brain share a unique anatomical similarity. They are both low-resistance, high-flow vascular beds. They are designed to receive massive amounts of blood flow continuously. Consequently, they are both highly susceptible to hemodynamic fluctuations and vascular damage. The same hypertension and endothelial dysfunction that scar the glomeruli of the kidneys also damage the small vessels in the brain's white matter. This leads to leukoariosis, or white matter lesions, which can be seen on MRI scans of kidney patients. These lesions represent areas of microinfarction, tiny strokes where the brain tissue has died due to lack of blood flow. Thus, the difficulty concentrating is not just a chemical issue, it is a structural one. The brain is suffering from a microvascular dementia that runs parallel to the renal failure. Furthermore, the impact of renal anemia, previously discussed in the context of fatigue, cannot be overstated here. The brain is the body's most voracious consumer of oxygen, utilizing approximately 20% of the body's total supply, despite representing only 2% of its weight. When the kidneys fail to produce erythropoietin, EPO, and red blood cell counts plummet, the brain is starved of oxygen. This state of chronic hypoxia forces the brain to prioritize survival functions over higher-order cognitive processes. Complex reasoning, emotional regulation, and concentration are the first systems to go offline to conserve energy. The patient becomes irritable, apathetic, and cognitively slow because their neurons are literally gasping for air. This hypoxic insult is compounded by the acidosis common in kidney failure, where the pH of the blood drops, further impairing neuronal function. The historical trajectory of this symptom is haunting. In the era before dialysis, uremic coma was a common terminal event. Physicians in the 19th and early 20th centuries documented the progression from mild confusion to delirium, convulsions, and finally,
unconsciousness. Richard Bright, the father of nephrology, noted the heaviness and drowsiness of his patients. Today, we rarely see full-blown uremic coma because dialysis intervenes, but we see a pervasive uremic impairment that affects millions. It impacts the workforce significantly. Many patients in the early stages of kidney failure face disciplinary action or job loss because their performance drops mysteriously. They are labeled as lazy or incompetent, when in reality they are intoxicated by their own metabolism. The psychological ramifications of this cognitive erosion are profound. The loss of mental sharpness strikes at the core of human identity. Patients often report a terrifying sense of detachment, as if they are observing the world through a thick pane of glass. They lose the ability to multitask, a critical skill in modern life. The frustration of losing one's mind can lead to severe depression, which in turn exacerbates the cognitive deficits. It becomes a vicious cycle. The uremia causes depression, the depression causes cognitive slowing, and the cognitive slowing leads to social withdrawal and further decline. Moreover, the sleep disturbances associated with kidney failure, sleep apnea and restless leg syndrome, prevent the brain from entering deep restorative REM sleep, preventing the cleaning of neural waste that happens at night via the glymphatic system, further compounding the toxicity. Research into the kidney-brain crosstalk is currently one of the most dynamic fields in medicine. Scientists are discovering that the inflammation generated by failing kidneys releases cytokines, inflammatory messenger molecules, that travel to the brain and induce neuroinflammation. The brain's immune cells, the microglia, become chronically activated, attacking healthy neural connections. This suggests that kidney failure is in part a neurodegenerative disease.
There is a statistically significant link between chronic kidney disease, CKD, and the development of Alzheimer's disease and vascular dementia. The difficulty concentrating in stage 3 CKD is a potential precursor to frank dementia in stage 5. In the clinical setting, this symptom is often missed because standard cognitive testing is not part of a routine renal workup. Nephrologists focus on creatinine and potassium, often overlooking the patient's complaint that they can't think straight. However,
tests like the trail-making test or the mini mental state examination often reveal significant deficits in executive function even in early-stage patients. Recognizing this sign requires a high index of suspicion. If a patient with risk factors for kidney disease, hypertension, diabetes presents with new-onset attention deficit or memory issues, the physician must look beyond the brain and check the kidneys. Ultimately, the difficulty in concentrating is a signal that the body's internal environment has become hostile to life. The brain, requiring a precise balance of electrolytes, pH, and clean blood to function, is the most sensitive barometer of this environment. When the kidneys fail to maintain homeostasis, the mind begins to unravel. It is a slow, silent erasure of the self, a fading of the intellectual light that defines our humanity. To ignore this fog is to allow the toxins to cement permanent damage in the neural pathways, turning a reversible metabolic state into an irreversible cognitive loss. 6. Dry and itchy skin, the dermatological scream, and the phosphorus plague. If the brain fog is the silent suffocation of the self, the dry and itchy skin associated with kidney failure is the screaming physical torture of the shell. This is not the mild dryness of a winter's day, nor is it the itch of a mosquito bite. This is uremic pruritus, also known as chronic kidney disease-associated pruritus or CKD-AP, a relentless, bone-deep sensation that affects up to 40% of patients with advanced kidney disease. It is a symptom that transforms the skin, the body's largest organ, into a landscape of torment. To understand this entry, we must reframe our understanding of the skin. It is not merely a covering, it is an excretory organ. When the kidneys, the primary filtration plant, shut down, the body attempts to divert the elimination of toxins to the skin with catastrophic results. The pathophysiology of this condition is a masterclass in biochemical chaos, centered primarily on the mismanagement of minerals, phosphorus and calcium. In a healthy body, the kidneys act as the thermostat for phosphorus, a mineral found in everything from dairy to dark sodas. When the kidneys fail, they lose the ability to excrete excess phosphorus. Levels in the blood skyrocket, hyperphosphatemia. At the same time, the failing kidneys stop activating vitamin D, which leads to a drop in calcium levels. The parathyroid glands verify this drop and go into overdrive, releasing parathyroid hormone, PTH, to leach calcium from the bones. The result is a blood supply saturated with both calcium and phosphorus. When the product of calcium and phosphorus concentrations exceeds a certain threshold, these minerals can no longer stay dissolved in the blood. They precipitate, they crystallize. Microscopic calcium phosphate crystals begin to deposit in the soft tissues of the body, including the dermis of the skin. These sharp, jagged microcrystals act as constant irritants to the nerve endings in the skin, triggering a sensation of itching that no amount of scratching can relieve because the source of the itch is under the skin, not on it. This is metastatic calcification, and it turns the skin into a mineralized shell. Simultaneously, the accumulation of uremic toxins, compounds that should have been urinated away, poisons the sweat and sebaceous or oil glands. These glands atrophy and shrink. The skin loses its natural ability to hydrate and lubricate itself. This leads to xerosis,
a severe form of dryness where the skin becomes scaly, rough, and lizard-like. The barrier function of the skin is compromised, allowing moisture to escape and irritants to enter. This dryness, xerosis, exacerbates the itch, pruritus, creating a feedback loop of misery. The skin may crack and fissure, creating portals for infection in an already immunocompromised patient. The sensation of uremic pruritus is distinct and horrifying. Patients describe it as crawling, burning, or electric. It is often worse at night, exacerbated by the warmth of the bed and the lack of distractions, leading to severe insomnia. The psychological toll is immense. The itch is inescapable. It does not respond to traditional antihistamines because it is not primarily histamine-driven like an allergy. It is a central neuropathic itch involving the opioid receptors in the brain and skin. The immune system is also implicated. Mast cells in the skin release tryptase and histamine in response to the systemic inflammation, but blocking histamine alone rarely solves the problem. The itch is a systemic alarm signal. Historically, the most extreme visual manifestation of this failure was uremic frost. In the days before effective dialysis, terminally ill kidney patients would present with a white powdery dust coating their face and chest. This was urea, the very substance of urine, being sweated out through the skin in such high concentrations that it crystallized upon evaporation. The patient literally became frosted with their own metabolic waste. While rare today due to earlier intervention, uremic frost remains a potent historical symbol of the skin's desperate attempt to save the body from toxic overload. It serves as a grim reminder that when the kidneys fail, the body becomes a closed loop of poison.
A more modern and equally terrifying complication related to these mineral imbalances is calciphylaxis, calcific uremic arteriolopathy. This is a condition where the calcium phosphate crystals deposit not just in the skin, but in the walls of the small blood vessels supplying the skin and fat. The vessels calcify and block blood flow, leading to ischemic necrosis. The skin literally dies and turns black. These painful, non-healing ulcers often appear on the thighs or abdomen and have a high mortality rate due to sepsis.
Calciphylaxis is the nuclear winter of kidney skin disease, a sign that the mineral metabolism is so deranged that the body is turning to stone and rotting simultaneously. The appearance of the skin in early kidney failure often holds subtle clues before these catastrophic stages. The skin may take on a sallow or yellowish-gray hue. This is due to the retention of urochromes, urinary pigments, that are depositing in the skin, combined with the pallor of anemia. The patient looks washed out, yet pigmented. Half-and-half nails, Lindsay's nails, are another specific sign, where the bottom half of the fingernail is white, edema, and the top half is red or brown. These dermatological signposts are the body's external dashboard, warning of the internal engine failure. The itch-scratch cycle leads to secondary damage. Patients with uremic pruritus often present with linear excoriations, scratch marks, all over their back and limbs. Over time, this chronic trauma leads to prurigo nodularis, hard, itchy bumps that form where the patient has repeatedly picked at their skin. These Picker's nodules are scars of the battle against the itch. The social stigma is profound. Patients may stop wearing short sleeves or going out in public because they look like they have a contagious skin disease or a drug addiction. The visible nature of these symptoms contrasts sharply with the invisible nature of the kidney failure itself, forcing the patient to wear their illness for the world to see. Philosophically, the skin represents the boundary between the self and the world. In kidney failure, this boundary becomes a source of pain. The patient is trapped in a tactile prison. The soothing touch of a loved one or the comfort of soft sheets becomes irritating or painful. The quality of life for patients with severe pruritus is comparable to those with chronic pain conditions. Depression and suicide risk are significantly higher in kidney patients who suffer from severe itching. It is a symptom that breaks the will to live, often more so than the fatigue or the dietary restrictions. Treatment of this condition reveals its complexity. It requires a multifaceted approach: phosphate binders to lower blood phosphorus, moisturizers for the xerosis, gabapentin for the neuropathic component, and UV light therapy to calm the skin's immune system. Recently, kappa opioid receptor agonists have been developed to target the itch pathways directly in the brain.
Acknowledging that this is a neurological as well as a dermatological issue. In conclusion, dry and itchy skin in the context of kidney failure is a profound physiological betrayal. It is the result of the body's chemistry being thrown into chaos, minerals precipitating into crystals, glands withering from toxins, and nerves firing uncontrollably. It transforms the skin from a protective barrier into a torture chamber. Recognizing this itch, especially when it is persistent, widespread, and unaccompanied by a rash, is critical. It is a cry for help from the blood, signaling that the filter is broken, the phosphorus is rising, and the body is beginning to mineralize from the inside out. To dismiss it as just dry skin is to ignore a systemic crisis that threatens the integrity of the entire organism.
The sensation is sudden, violent, and primitive. It often strikes in the dead of night, tearing the patient from sleep with a force that feels less like a biological function and more like a demonic possession of the limb. The muscle, usually in the calf or the foot, seizes into a rock-hard knot, locking the joint in a rictus of agony that can last for seconds or minutes. This is the muscle cramp, a symptom so common in the general population that it is frequently dismissed as a byproduct of dehydration or overexertion. However, in the context of failing kidneys, the muscle cramp is a harbinger of a profound electrical storm brewing within the body's fluids. It represents the catastrophic breakdown of the neuromuscular junction, the delicate interface where the nervous system commands the muscular system. To understand why kidney failure precipitates this agony, we must descend into the microscopic world of ion channels and the sliding filament theory of muscle contraction, revealing a narrative of chemical anarchy. The human body is, in essence, a bioelectric machine. Every movement from the blinking of an eye to the beating of the heart is governed by the flow of charged particles, electrolytes, across cell membranes. The kidneys are the master electricians of the system. They regulate the concentrations of sodium, potassium, calcium, magnesium, and phosphorus with a precision that rivals the most advanced computer algorithms. When the kidneys begin to falter, this delicate balance is shattered. The resulting chaos manifests most visibly in the skeletal muscles. The primary driver of these renal cramps is often the dysregulation of the calcium-phosphorus axis, a relationship that is fundamental to human physiology. Calcium is the key that unlocks muscle contraction. Inside the muscle fiber, calcium ions bind to a protein called
called troponin, which moves another protein, troponimyosin, out of the way, allowing the muscle filaments actin and myosin to slide past each other and shorten the muscle. In a healthy body, the kidneys filter out excess phosphorus found in the diet, preservatives, sodas, meats. When the kidneys fail, phosphorus accumulates in the blood, a condition known as hyperphosphatemia. Phosphorus is a chemical bully. It binds eagerly with calcium in the bloodstream, effectively neutralizing it and pulling it out of circulation.
This leads to hypocalcemia, low levels of ionized calcium available for use. The body, sensing this drop in calcium, enters a state of panic. The parathyroid glands located in the neck detect the low calcium and release parathyroid hormone, or PTH, in massive quantities. This hormone strips calcium from the bones to replenish the blood levels, leading to weak, brittle bones, renal osteodystrophy. However, in the immediate term, the fluctuating calcium levels wreak havoc on the nerves. Low calcium lowers the threshold for nerve depolarization. This means the nerves become hyper-excitable. They begin to fire spontaneously, without any command from the brain. These rogue signals scream down the motor neurons and slam into the muscle fibers, causing them to contract fully and uncontrollably. This is the mechanism of tetany, and it is the physiological root of the agonizing Charlie horse that plagues kidney patients. But the electrical failure is not limited to calcium. We must also consider the role of magnesium, the often overlooked relaxation mineral. Magnesium acts as a natural calcium blocker, helping muscles to relax after contraction. As kidney function declines, magnesium levels can become erratic. If they drop, the muscle loses its ability to unlatch. It stays contracted, trapped in a cycle of energy expenditure that produces lactic acid, adding a burning chemical pain to the mechanical crushing sensation of the cramp. Conversely, if magnesium accumulates to toxic levels, as kidneys fail to excrete it, it can cause weakness and reflex loss. The kidney patient walks a razor's edge between these two extremes, and the cramp is the sign that they have fallen off. Furthermore, the issue of volume status plays a critical role in the genesis of these cramps. Kidney failure is a disease of fluid management. As discussed in previous entries, patients oscillate between fluid overload, edema, and dehydration from aggressive diuretic use or dialysis. When the fluid volume in the blood vessels drops too quickly, a common occurrence during the last hour of a hemodialysis session or after a potent dose of furosemide, the perfusion to the muscles is compromised. The muscles, starved of oxygen-rich blood and the electrolytes needed to reset their resting potential, react with a spasm. This ischemic cramping is a desperate metabolic cry for help. It is the muscle tissue suffocating.
The historical context of treating these cramps reveals the desperation of both physicians and patients. For decades, quinine, a compound originally derived from the bark of the cinchona tree and used to treat malaria, was the gold standard for leg cramps. It worked by decreasing the excitability of the motor end plate. However, its side effects, including dangerous heart arrhythmias and blood disorders, led the FDA to ban its routine use for cramps. This left nephrologists with a limited arsenal: vitamin E, stretching exercises, and gabapentin. The loss of quinine was a blow to the renal community, highlighting how difficult it is to tame the electrical storms of a failing body without causing collateral damage. We must also explore the neuropathic element. Uremic toxins, the waste products the kidneys fail to clear, damage the peripheral nerves over time. This uremic neuropathy manifests as a dying back of the long nerve fibers, starting in the toes and moving upward. These damaged nerves are unstable. They are prone to misfiring. This connects the symptom of cramping to the symptom of restless leg syndrome, or RLS, which affects a staggering percentage of kidney patients. While RLS is a sensory creep-crawly feeling and cramping is a motor contraction, they are cousins in the same family of neurological dysfunction. The patient lies in bed, their legs twitching and jerking, unable to find peace because their own nervous system has turned against them. The psychological impact of chronic cramping is severe. It creates a fear of sleep. Patients know that the moment they relax, the attack will come. This leads to chronic insomnia, which exacerbates the fatigue and cognitive decline mentioned in earlier entries. The pain of a severe cramp can leave the muscle sore for days, limiting mobility and increasing the risk of falls. In the dialysis unit, the onset of a cramp is a dramatic event. The patient cries out, the machine alarms, and nurses rush to administer saline boluses to expand the blood volume. It is a violent interruption of the life-sustaining treatment, a reminder that the machine cannot perfectly replicate the subtle grace of the human kidney. In the broader scope of human physiology, the muscle cramp serves as a reminder of our evolutionary origins. We are creatures of the sea, carrying an internal ocean of saline within us. The ratio of salts in our blood mimics the primordial waters. When the kidneys, the guardians of this internal ocean, fail,
The salinity changes. The tides of sodium and potassium become erratic. The cramp is the violence of a drying ocean, the friction of a machine running without oil. It is a sign that the body's homeostatic mechanisms are overwhelmed, and the simple act of movement has become a liability.
8. Poor appetite or nausea, the gastric shutdown, and the metallic taste of death.
If the muscle cramp is the body's electrical rebellion, nausea is its chemical rejection of existence. The loss of appetite in kidney failure is not merely a lack of hunger, it is a profound visceral aversion to food, the very substance required to sustain life. This symptom, clinically termed anorexia, distinct from the psychological eating disorder, combined with persistent nausea and vomiting, constitutes one of the most debilitating aspects of the uremic syndrome. It is the result of a systemic poisoning that turns the act of eating into a form of torture. To understand this, we must look at the gut not just as a digestive tube, but as a sensory organ that is intimately connected to the brain and the blood, both of which are polluted in the absence of renal function. The primary driver of this nausea is the accumulation of urea. Urea is the nitrogenous waste product formed when the liver breaks down protein. It is the ash left over from the metabolic fire. A healthy kidney filters urea effortlessly. A failing kidney allows it to rise. Normal blood urea nitrogen, BUN levels, are 7 to 20 milligrams per deciliter. In untreated kidney failure, they can soar to over 100 milligrams per deciliter. This massive load of urea diffuses into every tissue, including the saliva and the gastric juices. Here, a gruesome chemical transformation occurs. Bacteria in the mouth and stomach possess an enzyme called urease, which breaks down this excess urea into ammonia and carbon dioxide. This hydrolysis of urea into ammonia is the cause of uremic failure, or ammonia breath. The patient's mouth literally tastes like urine. Food begins to taste metallic, bitter, or spoiled. This condition, known as dysgeusia, fundamentally alters the sensory experience of eating. A prime steak may taste like chewing on a copper penny. A glass of water may taste like dish soap. This is the metallic taste of death, often described in historical medical texts. When the sensory reward of eating is replaced by a noxious chemical assault, the appetite collapses. The brain, receiving signals of poison from the taste buds, shuts down the hunger drive to protect the organism. But the assault is not just in the mouth, it is in the stomach lining itself. High levels of urea cause uremic gastritis, inflammation of the stomach mucosa. The stomach lining becomes red, friable, and prone to erosion. This leads to a constant
gnawing nausea that is often worse in the morning. This morning sickness of kidney failure is a cruel mimicry of pregnancy, but instead of signaling new life, it signals organ death. The patient wakes up dry heaving, their stomach empty, but their nausea overwhelming. This is often the specific symptom that finally drives a stubborn patient to the emergency room, where the diagnosis of end-stage renal disease, or ESRD, is finally made. We must also consider the neurological trigger. The brain possesses a specialized area called the chemoreceptor trigger zone, or CTZ, located in the medulla oblongata. The CTZ is outside the blood-brain barrier, meaning it is directly exposed to the chemistry of the blood. Its job is to detect toxins and initiate the vomiting reflex to expel them. In kidney failure, the blood is saturated with middle molecules, toxins larger than urea that are poorly understood but highly emetic. These toxins constantly stimulate the CTZ. The patient is in a permanent state of motion sickness without moving. The brain is screaming poison and commanding the stomach to empty, but the poison is not in the stomach, it is in the blood. No amount of vomiting can clear it. The connection between kidney failure and diabetes, the leading cause of renal disease, adds another layer of complexity: gastroparesis. High blood sugar damages the vagus nerve, which controls the stomach muscles. The stomach becomes paralyzed, unable to grind food and push it into the small intestine. Food sits in the stomach for hours or days, fermenting and causing bloating, early satiety, and severe nausea. When a diabetic patient with kidney failure eats a small meal, they may feel dangerously full after only a few bites. This early satiety is a mechanical blockade that compounds the chemical nausea. The consequences of this anorexia are catastrophic. It leads to protein energy wasting, a state of metabolic cannibalism. The body, deprived of dietary fuel, turns on itself. It breaks down skeletal muscle to get amino acids for survival. However, this muscle breakdown releases more nitrogenous waste, which raises the BUN further, which increases the nausea. It is a self-perpetuating death spiral. The patient loses weight rapidly, yet this weight loss is often masked by fluid retention or edema. A patient may look puffy and obese due to water weight, while their actual muscle mass is dissolving underneath. This sarcopenic obesity is a major predictor of mortality. The social and cultural implications of this symptom are heartbreaking. Food is the glue of society. We celebrate with food, we mourn with food, we bond over meals. The kidney patient is exiled from this communal ritual. The renal diet is notoriously one of the most restrictive and unpalatable diets in medicine. It requires low sodium, no flavor, low potassium, no fruits or vegetables, and low phosphorus, no dairy or nuts. Imagine a patient who already has a metallic taste in their mouth and severe nausea being told they must eat bland, boiled white rice and avoid their favorite comfort foods. The act of eating becomes a medical chore, a joyless ingestion of calories. Family dinners become sources of anxiety and isolation as the patient picks at their plate, fighting the urge to vomit. Scientific research into the gut-kidney axis is revealing that the microbiome plays a massive role here. In kidney failure, the gut wall becomes permeable, leaky gut. Bacterial toxins, endotoxins, leak from the intestine into the bloodstream, driving systemic inflammation. Furthermore, the composition of the gut bacteria changes. Good bacteria die off, replaced by bacteria that produce uremic toxins like P-crestal and indoxyl sulfate. These toxins, produced in the gut, travel to the kidney and accelerate fibrosis, while also traveling to the brain to worsen the nausea. Treating the gut with probiotics and charcoal-based adsorbents is a frontier in trying to break this cycle. Historically, the smell of uremic breath was a diagnostic tool long before blood tests. Physicians would lean in to smell the patient's breath. A urine-like odor can front diagnosis of dropsy or Bright's disease. It was the scent of the body failing to clean itself. Today, we have antiemetic drugs like ondansetron and metoclopramide, but they are often band-aids. The only true cure for uremic nausea is dialysis or transplantation. When a patient starts dialysis, one of the first signs of recovery is the post-dialysis hunger. As the machine clears the urea, the metallic taste fades, and the brain releases the brake on the appetite. The return of hunger is often celebrated as the return of life. In conclusion, poor appetite and nausea and kidney failure are not minor gastric upsets. They are the result of a total systemic toxicity that corrupts the senses and the brainstem. The body, flooded with its own waste, rejects the external world.
It refuses intake because it can no longer handle output. This symptom is a profound rejection of the biological imperative to consume energy, signaling that the metabolic machinery has ground to a halt. When food, the most basic pleasure and necessity of life, becomes repulsive, the organism is in the advanced stages of collapse.
9. Shortness of breath, the drowning of the alveoli, and the oxygen famine. The sensation of breathlessness, medically termed dyspnea, is perhaps the most primal and terrifying of all physiological distress signals. It strikes at the very foundation of survival. In the context of kidney failure, this is not the panting that follows a sprint, nor is it the wheezing of an asthmatic. It is a suffocating, crushing weight that sits upon the chest, a relentless air hunger that persists even when the body is perfectly still. To investigate this symptom is to uncover a dual catastrophe, a mechanical failure of the lungs caused by fluid overload and a chemical failure of the blood caused by severe anemia. It is a scenario where the patient is effectively drowning from the inside while simultaneously starving for oxygen at a cellular level. The primary architect of this respiratory distress is pulmonary edema, fluid accumulation in the lungs. As we have established in previous entries, the failing kidney loses its ability to regulate fluid volume. It stops excreting the water we drink and the sodium we eat. This excess fluid has to go somewhere. Initially, it settles in the legs, peripheral edema, obeying the laws of gravity. However, as the volume overload becomes critical, the fluid backs up into the venous system and eventually into the pulmonary circulation. The pressure within the delicate capillaries of the lungs rises, overcoming the structural integrity of the alveolar capillary barrier. Plasma is forced out of the blood vessels and into the alveoli, the millions of tiny air sacs responsible for gas exchange. This is a physical invasion of the respiratory territory. The alveoli, designed to be dry, air-filled chambers where oxygen meets blood, become waterlogged swamps. The surface area available for gas exchange plummets. The patient breathes in, but the oxygen cannot penetrate the wall of fluid to reach the bloodstream. This manifests clinically as crackles or rales when a physician listens with a stethoscope, the sound of air bubbling through water. For the patient, the experience is horrific. It feels as though a heavy stone has been placed on the sternum. The simple act of expanding the ribcage becomes a muscular war against the stiffness of the wet lungs. A distinct and clinically significant feature of this fluid overload is orthopnea, the inability to breathe while lying flat. During the day,
Gravity keeps much of the excess fluid in the lower extremities, but when the patient lies down to sleep, that fluid redistributes. It rushes from the legs back into the central circulation, overwhelming the heart and flooding the lungs. This leads to a terrifying phenomenon known as paroxysmal nocturnal dyspnea, PND. The patient wakes up gasping for air, bolting upright in a panic, often rushing to a window to breathe fresh air, though the quality of the air is not the issue. This forces patients to sleep in recliners or propped up on stacks of 3 or 4 pillows, a lifestyle modification that is a classic yet often overlooked hallmark of heart and kidney failure. However, the fluid is only one head of the hydra. The second driver of shortness of breath is renal anemia, a condition we touched upon regarding fatigue, but must now analyze through the lens of respiration. The kidneys produce erythropoietin, EPO, the hormone that signals bone marrow to create red blood cells. As kidney tissue dies, EPO production halts. The red blood cell count crashes. Hemoglobin, the molecule that taxis oxygen from the lungs to the tissues, becomes scarce. A patient with advanced kidney disease may have half the normal amount of hemoglobin. This creates a paradoxical situation. The lungs might be clear if fluid is managed, but the blood cannot carry the oxygen they provide. The body is breathing, but the tissues are suffocating. To compensate, the respiratory rate increases. changes. The brain, sensing the cellular hypoxia, low oxygen, commands the diaphragm to work harder and faster. The patient feels constantly winded, even at rest. Walking to the mailbox feels like summiting Everest. This is high output failure, where the heart pumps furiously to circulate the thin, watery blood faster, trying to deliver enough oxygen to keep the organs alive. Eventually, the heart muscle creates its own demand for oxygen that the blood cannot meet, leading to angina and further respiratory distress. There is a third, darker chemical component to this breathlessness: metabolic acidosis. The kidneys are the body's primary acid-base regulators. They excrete hydrogen ions and regenerate bicarbonate, the buffer that neutralizes acid. When this function fails, the blood becomes acidic. The body, in a desperate attempt to correct this pH imbalance, uses the lungs as a backup system. By breathing deeply and rapidly, the body can blow off carbon dioxide, which is acidic.
This specific pattern of deep labored breathing is known as Kussmaul respiration. It is the sound of the body trying to exhale its own toxicity. The patient is not short of breath due to exertion. They are hyperventilating to prevent their blood from turning into acid. Historically, this symptom was often misdiagnosed as cardiac asthma or pneumonia. In the 19th century, before diuretics like furosemide or the advent of dialysis, the treatment for this dropsy of the chest was brutal. Physicians would perform phlebotomy, bloodletting, to reduce the fluid volume, a practice that temporarily relieved the congestion but worsened the anemia, often hastening death. The death rattle described in literature, the gurgling sound of a dying patient, was frequently the sound of terminal pulmonary edema in undiagnosed kidney failure. It wasn't until the development of the artificial kidney by Willem Kalf in the 1940s that we had a tool to physically pull this fluid out of the blood, allowing the patient to take a full breath again. The psychological impact of chronic dyspnea is profound. Breath is life. In many cultures, the word for spirit and breath is the same, pneuma in Greek, ruach in Hebrew. To be denied breath is to be denied the essence of being. Patients with kidney failure live with a low-level anxiety that spikes into terror whenever the fluid accumulates. They become hyper-aware of every inhalation. Social interactions are curtailed because talking requires breath they cannot spare. The air hunger triggers primal panic centers in the amygdala, leading to a state of constant fight or flight arousal that exhausts the already depleted reserves of the patient. Furthermore, the interplay between the heart and the kidney, the cardiorenal syndrome, is most evident here. The fluid overload from the kidney strains the heart, causing it to dilate and fail, congestive heart failure. The failing heart then pumps less blood to the kidneys, causing them to fail further. It is a death spiral. The shortness of breath is the siren song of this spiral. It indicates that the heart can no longer manage the volume the kidney is refusing to excrete. In the modern clinical landscape, the management of this symptom is a tightrope walk. Nephrologists must balance drying out the patient to help them breathe against the risk of dehydrating the remaining kidney function. It involves a complex regimen of high-dose loop diuretics,
fluid restrictions, often less than 1 liter per day, and eventually dialysis. The dry weight, the target weight of the patient after excess fluid is removed, becomes the holy grail of treatment. When a patient on dialysis comes in gasping for air, they are often 5 or 6 kilograms over their dry weight, carrying 6 liters of extra fluid in their thoracic cavity. Culturally, we often associate shortness of breath with the lungs, smoking, COPD, or the heart, obesity. The kidney's role is invisible to the public eye. This leads to delayed diagnoses. A patient goes to a pulmonologist for asthma that doesn't respond to inhalers, or a cardiologist for heart failure that resists standard treatment, only to find later that the root cause is renal. The breathlessness of kidney failure is a masquerader. It hides behind the guise of other diseases until the blood work reveals the truth. The creatinine is high, the hemoglobin is low, and the blood is acidic. Looking to the future, bioimpedance technology is being integrated into wearable devices to monitor intrathoracic fluid levels before symptoms appear. Smart vests that can detect the electrical resistance of the chest cavity could alert patients to wet lungs days before they feel the first gasp. But until then, the shortness of breath remains a critical, late-stage alarm. It is the body signaling that its hydraulic systems have failed, its oxygen transport is offline, and it is drowning in the byproducts of its own existence. It is a cry for help that is often silent, as the patient simply does not have the breath to scream.
10. High blood pressure that won't improve, the hydraulic feedback loop, and the vascular destruction. The final entry in this investigation is not just a symptom, it is both a cause and a consequence, a relentless Ouroboros of destruction that defines the pathology of kidney failure. High blood pressure or hypertension is the silent killer, but in the context of renal disease, it is a loud screaming alarm that refuses to be silenced by standard medication. This is resistant hypertension, blood pressure that remains elevated despite the concurrent use of 3 antihypertensive agents of different classes. To understand why this pressure won't improve, we must dismantle the popular misconception that the heart is the sole regulator of blood pressure. In reality, the kidney is the master commander of the cardiovascular system, and when it goes rogue, it initiates a vascular war that destroys the body from the inside out.
The mechanism at the heart of this struggle is the renin-angiotensin-aldosterone system, or RAS. This is a hormonal cascade of immense power, evolved over millions of years to save our ancestors from bleeding to death or dying of dehydration. When a healthy kidney senses low blood flow or low sodium, it releases an enzyme called renin. Renin converts a liver protein into angiotensin 1, which is then converted by the lungs via ACE enzymes into angiotensin 2. Angiotensin 2 is the most potent vasoconstrictor in the human body. It clamps down on the arteries, skyrocketing blood pressure instantly. It also triggers the release of aldosterone, which commands the kidneys to hoard sodium and water, increasing blood volume. In a healthy scenario, this system turns off once pressure is restored. In kidney failure, the switch is broken. The scarred ischemic kidney tissue mistakenly believes it is starving for blood because its own vessels are hardened and narrowed. In a panic, it continuously pumps out renin. It floods the body with angiotensin 2. The arteries are clamped shut in a permanent state of high-tension constriction. Simultaneously, the failing kidney loses its ability to excrete sodium, natriuresis. The patient eats a normal diet, but the salt stays in the blood, pulling water with it. The result is a closed hydraulic system where the volume is increasing, fluid retention, and the pipes are narrowing, vasoconstriction. The pressure within the system becomes astronomical. This creates a vicious feedback loop.
The high pressure hammers the delicate capillaries of the glomeruli, the kidney's filters. These capillaries are designed for low pressure filtration. Under the assault of systemic hypertension, they undergo barotrauma. The vessel walls thicken and harden, arteriolosclerosis, to protect themselves, which further reduces blood flow, which triggers more renin release. The glomeruli eventually collapse and turn into scar tissue, glomerulosclerosis. This is why hypertension is the second leading cause of kidney failure after diabetes, and why kidney failure almost always causes hypertension. They are two sides of the same coin, locked in a death spiral. The clinical presentation of this secondary hypertension is distinct. It is stubborn. A patient might be on a diuretic, an ACE inhibitor, a calcium channel blocker, and a beta blocker, yet their systolic pressure hovers dangerously at 180 or 200 millimeters mercury. They may experience crushing headaches, particularly in the morning, occipital headaches, visual disturbances like blurred vision or floaters due to retinal damage, hypertensive retinopathy, and a bounding pulse that feels like it will burst through the skin. However, often there are no symptoms until a catastrophic event occurs, a stroke, a heart attack, or an aortic dissection. The pressure erodes the vessel walls silently, creating weak points, aneurysms, that eventually rupture. Historically, the connection between the kidneys and blood pressure was a monumental discovery. In the early 20th century, the Goldblatt kidney experiment demonstrated that clamping the renal artery of the dog caused systemic hypertension. This proved that the kidney was the thermostat of pressure. Before effective antihypertensives, malignant hypertension, rapidly progressing high BP, was a death sentence, often leading to kidney failure and death within months. The most famous case is perhaps Franklin D. Roosevelt, whose blood pressure was recorded at levels like 300/190 millimeters mercury shortly before his death from a cerebral hemorrhage. His untreated hypertension was likely driven by undiagnosed cardiovascular and renal issues, a testament to the limited understanding of the time. The sociological implications of this entry are vast, particularly regarding diet. The modern industrial diet is a sodium bomb. Processed foods, preservatives, and restaurant meals are saturated with salt. For a person with healthy kidneys, this is manageable. For a person with early-stage kidney disease,
it is poison. The compromised kidney cannot excrete this load. This has led to a public health crisis where salt sensitivity is rampant. The cultural addiction to salt fuels the hypertension that destroys the kidneys, which then drives the pressure higher. It is a man-made environmental hazard, interacting with biological vulnerability. Furthermore, the concept of dipping is crucial here. In healthy individuals, blood pressure drops by 10–20% during sleep, a phenomenon called nocturnal dipping. It gives the cardiovascular system a rest. In kidney failure, this dipping is lost. The patient is a non-dipper. Their arteries are subjected to high pressure 24 hours a day, 365 days a year. This relentless pounding accelerates end organ damage. The loss of dipping is often one of the earliest signs of renal dysfunction, detectable only by 24-hour ambulatory blood pressure monitoring, a technology that is underutilized. The management of this resistant hypertension often requires a philosophical shift in the patient's life. It is not just about taking pills, it is about volume control. Because the root cause is often fluid and sodium retention, the most effective treatment is often aggressive diuresis, or in advanced stages, dialysis to physically remove the fluid. This leads to the phenomenon of dialyzable hypertension, pressure that is high before a dialysis session and normal after. It proves that the pressure was hydraulic, not just vascular. In the future of medicine, we are looking toward renal denervation. This is a procedure where a catheter is inserted into the renal arteries to ablate the sympathetic nerves to wrap around them. These nerves carry the stress signals from the brain to the kidney and vice versa. By severing this communication, we can theoretically calm the kidney down, stopping the renin release and lowering blood pressure without pills. Early trials have been mixed, but the technology is evolving. We are also seeing the rise of genetic profiling to see which patients have overactive RAS genes, allowing for precision medicine, prescribing the exact drug that targets the patient's specific molecular flaw.
Ultimately, high blood pressure that won't improve is the definitive sign that the body's regulatory authority has collapsed. The kidney, which should be the benevolent governor of flow and pressure, has become a tyrant. It sacrifices the heart and the brain in a misguided attempt to preserve its own perfusion.
Recognizing this specific type of hypertension, resistant, non-dipping, and volume-dependent, is the key to saving the remaining kidney function. It is a battle against physics and chemistry, where the pressure in the pipes threatens to blow the entire house down. When the numbers on the cuff refuse to drop, it is the kidney screaming that it has lost control. Conclusion: the silent countdown. The investigation into these 10 signs reveals a terrifying truth. Kidney failure is not an event, it is a process. It is a slow-motion car crash that happens over years, hidden behind vague symptoms like fatigue, itchiness, and a change in appetite. The body is incredibly resilient, compensating for the loss of function until it reaches a breaking point. By the time the breath is short and the limbs are swollen, the damage is often irreversible. The transition from health to dialysis is paved with ignored signals. These signs, the foamy urine, the metallic taste, the midnight cramps, are the language of a dying organ. In a world of high-tech medicine, the most powerful diagnostic tool remains the patient's own awareness. To listen to the kidneys is to listen to the quietest, most diligent workers in the human body. When they stop working, the silence is replaced by the roar of toxicity. The key to survival lies in decoding the whisper before it becomes a scream.